Okay, why don't we begin? It really is a personal privilege for me to introduce Dick Scott. I've worked with him a number of years. On a very personal note, I think I first encountered the name Scott with Scott and Blau when I was a graduate student at another university, the University of Michigan. And you know, your image when you're 25 years old and you're reading these legendary books is, you know, these guys are just sort of old and crotchety and so forth and so on. Right. 10 years later, to fast forward this, I happened to be sitting on a study section or some kind of advisory committee with Scott, and here he was, just a decent, nice, humane person. It was just a wonderful experience. And ever since then, it's been a very close and rewarding relationship. Dick is presently Professor Emeritus in Sociology. I think since the beginning of time he was professor, and it just recently became Emeritus. But I think what is also interesting when you look at his work at Stanford, he's also clinical or courtesy appointments in the School of Medicine, in the School of Business, in the School of Education, and for a number of years, I think more than 10, headed up, was the founding director of their Center of Organizational Studies, which was a unique thing that brought all the people who were interested in organizations to interact together. If you've been thinking about multi-level interventions, this clearly had to be one of these things. I mention all this because several points. Number one, the fact that he's been involved in 4 or 5 different schools reflects a really broad exposure and interest in the major social issues of our time and the ability of sociology to contribute to really dealing with the conceptual and analytical issues associated with understanding organizations, how they function, what are the factors affecting their change over a period of time. These are major, major things. Secondly, I'd like to point out, as I look around the room, I'm reminded, is that not only has Dick been very busy in publishing books and papers, and I can't remember how many, but it's a pretty impressive list. He also has been very productive in turning out some of the new scholars, of which we have a significant number in this room, who have been either his students or exposed to him in a particular way, for which we're most grateful, because these people will continue to work in an area that I think is where the future is and where we're going. The third thing I want to mention is the fact that I mentioned he's emeritus, and in one of the conversations I had with with Dick, maybe 2 or 3 years after you achieved emeritus status, he said, "I'm flunking retirement." You know, that was a very profound statement because, on the other hand, as we all deal with these kinds of things, I think of myself, but more importantly, in his case, he continues to make a tremendous contribution while he's flunking retirement, in which he's currently added to his repertoire of activities, his portfolio, where he's involved with the engineering community, civil and environmental engineers. And if I may be so bold as to advertise a forthcoming book, Cambridge University Press, Global Projects, Institutional and Political Challenges. I think it's going to be a real winner. Dick, thank you very much.
This seems like an odd time for a keynote somehow. Or after the talk, it's more like a swan song, I think. It's clearly the end. But I'm here because I was persuaded to come by Arnie and by the two Steves. I appreciate the invitation. And as you heard from Arnie, I'm an organization sociologist, and I've primarily concentrated my attention on studying professional organizations, schools, research institutes, hospitals, healthcare organizations, and now engineering firms. I'm not an expert, as you will quickly find out. I'm not an expert on cancer care systems. Everyone in this room knows much more about that than I do. What little I know, I learned when I was on the advisory board working with Arnie and Dick Warnicke on the CCOP intervention program, and I thought that was fascinating work. I've looked over a number of the papers before I came, and I've listened to the discussion today. I'm very pleased to observe yet another locale in which there is thoughtful and productive interaction between social scientists, medical scientists, and researchers across the spectrum. So, and I could comment on, I could, if I wanted to, comment a little bit on the papers, but I'll sort of refer to them in a glancing way. I thought the most useful thing I could do with my sort of 30 minutes of allotted fame here is to offer a somewhat related but alternative framework for thinking about multi-level analysis. But first, a couple of background comments. I sort of grew up with the field of organization studies. As Arnie said, I began in Chicago working with Peter Blau, and he was one of the founding people that sort of created a new, more macro-level approach. And so, as a part of that process, one of the things I've observed is over time an expanding sort of levels of analysis world in which we began by thinking about organizations primarily as environments within which individuals behaved, and then we began to think about organizations as themselves having structures and certain kinds of distinctive competence. And then we moved up to look at the interaction sets and the exchange partners that they had, and then we moved up to looking at types of organizations, and finally, we moved up to the level of organization fields. And I'll come back to organization fields because from my standpoint, and I think for this group, I think organization field provides a very nice possible focus for multi-level work because it encompasses the individual, the structural, the population level, and provides a framework within which one could talk about those things. In addition to expanding levels of analysis, there have been over time expanding scope of variables. We began by looking fairly narrowly at organizations as instrumental systems. We used sort of economic exchange models and so on. Then we began to think about power and politics, both intra and inter-organizational, moved to look at relational systems, and then more symbolic and cultural elements. And then finally, and more recently, to look at these as sort of knowledge systems that really needed to mobilize and create and increase the capacity in that way. Now, I think the expanding perspectives that we're talking about are very nicely reflected in all the papers we've heard and the papers that I looked over for the conference. They all take seriously the importance of social context and the central role that it plays in explaining behavior. They all recognize the complexity of this context, the fact that they're interacting and reciprocally interdependent variables. They recognize that there are multiple types of variables that are operating, political, social, economic, psychological, and so on. And as we also have heard, because cancer care is a prolonged process, all this takes place over very often long periods of time and across multiple types of systems. And so there's a lot of complexity there to look at, which I think we can get our heads around by looking at the perspective of fields. And so that perspective is one which takes as the focus of attention a set of organizations that in the aggregate are doing similar kinds of things. So think about cancer care organizations, for example. But also, not just the population. You think about the key suppliers, the key exchange partners, the key regulators, the key funders, both vertical and horizontal connections, because they are important players in this thing called field. And an alternative definition that I've offered is the notion of field connotes the existence of a community of organizations that partakes of a common meaning system and whose participants interact more frequently and faithfully with each other than with those outside the field. Now, what does it mean more concretely to take an organization field perspective? Well, an approach that my colleagues and I developed at Stanford several years ago was to think about, well, what are the critical components of fields? Well, there are actors. And the actors are both individual and collective. There are patients, there are physicians, there are nurses, there are healthcare systems, there are hospitals, and so on. Those actors vary in terms of being more or less central, peripheral. Some of them are more emergent, as in social movements. Some of them are highly established and highly vested in their environment. So there's the actor component, number one. Number two, and I think this is the most neglected part in the discussions I heard today, there's also a set of institutional logics. That is, what are the cognitive and the normative assumptions associated with each of those kinds of actors? Each brings a somewhat different set of perspectives. And in a world like cancer care, where there's so many different kind of professional groups, different kinds of physicians, different kinds of nurses, different kinds of legal people, different kinds of administrative people, in this world, you find a wide range of really quite differing and very often conflicting sets of values, assumptions, perspectives, belief systems, and so on. And so we need to take into account actors and their associated beliefs, norms, expectations, values, and so on. And then third, all of this takes place within a set of frameworks, and many of those governance frameworks. And these are frameworks that attempt to provide for some means of coordination, control, order, stability, whatever. And those, of course, frameworks exist both at the organizational level, at the multi-organizational level. There may be alliances and that kind of thing among organizations, but also on up to the state and the national levels and so on. So all of a sudden we've got a lot of different levels and types of phenomena going on here. In addition, fields, of course, organization fields are always subcomponents of larger societal systems, and the societal systems increasingly are subcomponents of larger transnational systems. So we always recognize that even though this is a complex entity, we have to see it as a part of a larger system and framework. Now, just thinking about the larger environment of the healthcare system, one of the things I didn't hear as nearly as much about as I wanted to was the fact that if you want to talk about context, seriously, in Las Vegas, California, in the United States of America, you have to recognize very, very forcefully what a distinctive context this is. What a distinctive context the American context is, particularly in healthcare. Tom Vogt alluded to this, but we really need to give a lot more attention to this as affecting virtually everything we were talking about today. To begin with, in the United States, much more so I think than in most countries, the boundary between the healthcare system and any of the fields that go in the healthcare system is much more permeable and much more invaded by broader societal logics than it is in many countries. The healthcare system is really highly vulnerable and highly open to a wide range of political and social and external societal forces. And when we talk about multi-level interventions, you don't sort of hold constant the societal level. It's going to be there. In fact, this conference almost didn't happen because of events at the societal level. So that has to be very much in mind. Think about the values of the society. Very much a market orientation. We think the market solves everything, and we think the government is the problem instead of the solution. There's a whole set of assumptions there about the conditions under which healthcare is provided that constitute a set of very important boundary assumptions on the kind of interventions that we try to examine and try to study. It's a very federalized system. The national government is very distinct from the state governments, and the state governments are very separate and different and very distinctly unique across the societies. And so when we talk about what's happening at the state level, we say, well, what state? Which state? What state are you talking about? And so these are another set of variables. We live in a society in which there's enormous attention to and emphasis on the freedom and the autonomy of individual actors. And so there's a suspicion of any kind of authority or any kind of control. And particularly in the medical world, there's an enormous amount of attention to the prerogatives and the autonomy of the providers and so on. These are all in factors that have an enormous effect on what we're talking about. A little more locally, in terms of the funding environment for looking at intervention in healthcare systems, there's the funding environment and the insurance companies and those kind of agencies. There's the structure of research funding, the structure of NIH, and the disease orientation, the disease-focused orientation of the different branches of that, with respect to the foundations, what are their agendas for research? And so all of those things begin to have an enormous effect on what kind of interventions are possible, what kind of interventions can be sustained, and so on. And so we live, the healthcare system generally, is a part of a very distinctive societal context that is continually intervening in the kind of things we think we're trying to study and examine and perhaps try to change. We use this field level model in our study to look at the structure of generally medical care delivery systems in one complex area, the San Francisco Bay Area. And we looked there at a 50-year period, speaking of time, taking a longitudinal approach of what are the changes that have occurred in the healthcare system of the United States, or at least in a significant specialized case within the United States. And in terms of actors, for example, going back to the list, in terms of actors, we found over time the physicians and the nurses and the other kinds of individual providers have become, of course, much more numerous, but also much more specialized than they were 50 years ago. The physicians are increasingly organized into groups, both actual and virtual. There are new types of roles of all kinds that didn't exist at all, of course, 50 years ago. The more generalized organizations like community hospitals are increasingly being replaced by the specialized agencies and the urgent care centers and the renal dialysis centers and so on. Nonprofit forms increasingly replace or challenge for-profit forms, and so enormous changes over time in what kind of actors. With the institutional logics, we begin with a period in which, by and large, most of the logics were dominated by physicians and by the profession of medicine, moving into a context later where the federal government begins to worry not only about quality of care as defined by physicians, but about access and equity and those kinds of concerns. And then you begin to move toward a concern now with increasing attention to the logics of efficiency, cost effectiveness, and cost attainment in a more recent period. So the governance structures, began with largely professional associations, were of course added to by federal and state regulatory groups, and so there have been changes across the board there. And so at the present time, if you look at the larger medical care system, these really very highly differentiated, specialized actors coexist together with their conflicting logics, creating a kind of a cacophony, which really has an enormous effect on the provision of medical care in this country. Now, let me say just a couple of words about the advantages of a field-level conception for multi-level approaches. First of all, I think it stresses the centrality of organizations to the way in which things happen in modern society. I think organizations are the major actors in a complex modern society. You know, we created organizations to be our agents, and increasingly most of us, you and I, are now their agents. And they have an enormous effect on how we organize our world and our work. It shifts attention. Most of the levels, tables, and so on talk about different variables and different measures. It shifts attention from generalized attributes and factors to talk about specific actors, specific types of actors embedded in particular contexts. It customizes the notion of levels and says, okay, there are levels, but the levels are occurring within what kind of setting, within what kind of larger field. It is very heuristic. You can use field boundaries to talk about the whole healthcare delivery system, the whole medical establishment if you want to. You can also use it to go down to talk about specific policy arenas, or you could use, for example, this to talk about what is the organizational field that develops around a particular type of intervention, a particular type of agency. If we want to intervene in this way, what are the kind of social, individual, and collective actors? What are the logics they bring? What are the governance structures going to be activated? You could look at that as a way of bounding the field of interest to your research. They're dynamic. There's a lot of emphasis in the papers, in Jeff's paper and others, on the importance of time. These structures are best mapped and understood over time. They are developing and changing over time. It encourages, indeed almost forces us to think about more longitudinal approaches and models. One of the best books that talks about these kind of issues is a recent book by Paul Pearson called Politics in Time. And he says almost all of our social science analysis neglects the historical dimension. We don't realize the extent to which most of the effects we observe have long-term, most of the outcomes we observe have long-time effects, and most of the interventions we have long-time outcomes. And they're just censored, right and left censored. The field approach, because it's deeply embedded in an institutional perspective, emphasizes the coexistence and the interdependence of both cultural and structural factors. Actors have particular locations in relational space. They also have distinctive identities. They have distinctive interests. It's very important to think about the cultural material that surrounds the kind of actors that we're trying to understand. It's like to think about looking at action is like trying to look at an actor in a play without knowing what the plot is. It's like trying to look at a player engaged in a game and not knowing what the game is about. You really need to ground the action. The context, the meaningful context, is not only structural, it is also cultural, and that needs to be unpacked and understood. It also, it's a wonderful approach. The field approach also accommodates this ongoing, ever-present tension between structures and actors. It recognizes that actors are embedded in contexts, that they are constrained by those contexts, but they're also empowered by those contexts, and it recognizes the actors are themselves agents. And when I say actors, I mean both organizations and individuals. This concept of a dynamic relationship between structures and actors was greatly advanced by two kinds of developments. One, Anthony Giddens' work on structuration theory that recognizes that the duality of agency and context, that context both grows out of action and agency, but also then provides a setting in which further action takes place. And also the introduction now of strategic and economic arguments makes us recognize that actors very often react to their context in very strategic ways and not simply in dumb conforming ways. You don't have to assume that we are cultural dopes in order to take an organization field perspective. And finally, this notion really celebrates the notion that contemporary modern societies are really composed of local social orders. These are the building blocks of our contemporary society. So as my colleague Neil Fligstein says, the theory of fields is a generic theory of social organization in modernity. So that's why we need it. I've got several more pages. Let me see just a couple more things. First of all, it's very important to recognize that these institutions that surround the fields and that comprise the fields, because they penetrate actors and the logics and the governance structures, these are not unitary, but really very often conflict. And a lot of the interest in these fields is about the kind of conflicts that occurs. So that in one of the best studies I know of a multi-level analysis of a medical care field, Carol Heimer and her colleagues, she's at Northwestern, have done a very nice analysis of of the behavior and attempts to understand the behavior of people in a neonatal intensive unit. And of course, she finds there that there are three major complexes of institutions that are at work that converge here: the medical professionals, that's broadly defined, the state and its legal and regulatory requirements, and then the parents and the relatives. And she points out because that most of these encounters take place in a medical setting, the presence and the pressure of the professionals and their standards becomes dominant. The major logics that are involved in these kinds of settings are medical standards and medical criteria. Although, as the time concept would point out, before the birth occurs or the neonatal child appears, of course, there are other contexts were dominant, the family context and so on. Later in the course of the development, other kinds of contexts. But if you choose which ones are dominant, depending on what you want to focus on. And Heimer suggests that one of the ways to think about this is that in many ways you can think about it as a kind of a garbage can model. And the question is, well, how are decisions made and what happens in this kind of setting? And the question is, well, who's present? Who has standing to make decisions and so on? Who has the right to say what a problem is? Who has the right to define what a solution is? And she talks about how do the logics get played out in this setting, depending on the answer to those kinds of questions. And then very specifically, she talks about looking carefully at the effect of legal institutions, for example, in neonatal units. And she finds out, for example, their effect is quite variable, and it depends a lot on what kind of law you're talking about and how the law gets activated. And so, for example, there's civil law, and to the extent that that institutional form enters into the field depends upon, she says the behavior there is highly reactive, and it's because of the concern for medical malpractice, and so the managers and providers take all kinds of steps to avoid medical malpractice in a highly reactive way. So it's dealt with because of the consequences of not dealing with it. Whereas, for example, criminal law is much less likely to intervene, and the only way it comes in is when physicians think they see absence of child neglect or child punishment of some kind, and so they use that law, they bring it in, they're the agents to say, we need to get a court order, and then they bring it in. And so the presence of these larger environmental elements gets activated by particular actors because of their interest and agenda in the setting. And you need to understand, as I say, what the actors' interests are and what the setting's about. And so let me just conclude by saying, let me illustrate a few of the ways in which this multi-level perspective might be the multi-level approach might be embedded in a organization field perspective. Think about, for example, the effect of law and politics. Well, you would want to look at what is the receiving organization that's subject to those laws? If it's a highly visible medical center, then it's going to be more likely to be influenced. It's going to be more likely to have a role in shaping those policies and so on than if it's in the periphery of the field. You need to think about the effect of time. How long has this set of interventions or this set of approaches gone on? How mature is it? What's the level of degree of consensus among the providers and the players there? One needs to look at the effect of specific community contexts. What are the community demographics? What are the socioeconomic status of the patients and the families in the area? What's the strength and activity of specific interest groups? And then finally, there's the effect of the organization and its participants and the demography and their relative power and influence within the organization itself. So in sum, I think one of the better ways to approach a multi-level analysis is to think about the setting boundaries around a specific field to be examined from this context. It allows you to focus on social structural aspects, on symbolic cultural aspects in a historical context. And it allows us to examine the interplay of these multiple forces as they work themselves out over time. And so my own priors would be to say, think a little bit about the possibility of using that kind of analytic, it's not a theory, but it's a conceptual framework to help us frame and to bound these conditions and these systems that we're trying to study and make interventions in. Thanks a lot.
Dick, thank you very much. I think the notion of fields, permeability of boundaries is a very central kind of idea that I think we need to spend more attention and pay attention to. Particularly intrigued with your comments on the legal aspects, and because here's another profession that plays many, many different roles as it interacts with the clinicians and the managers and can have a very important influence depending upon what is the issue involved. I'm currently living with this now because my daughter's a lawyer for the insurance company. When she goes into these conversations, I ask her to use her married name rather than her professional name, but we get along pretty well. We have a couple of minutes for questions, and I'm sure Dick would like to respond to any points of clarification or comments or questions of one sort or another. Yeah. Yes, sir.
Ron Myers from Jefferson, Philadelphia. I appreciated the comments because it actually took me back to my dissertation days when I did a dissertation on serological testing for HPV infection among Korean immigrants in Philadelphia. And I didn't know it then, but I guess what I was doing multi-level intervention analysis. There was a team at an institution that I was doing a postdoc in that was going out to Korean churches offering serological testing to Korean immigrant churches. And they observed that there was a differential response to their interventions that is going out to the field. That sometimes they would go out, they would have a very low response rate, 10%. Other times they would go out, they would have a 90% response rate of people actually coming up and being tested. So they were very confused by this, and the coincidence was that I was a postdoc and I was a Peace Corps volunteer in Korea. I spoke Korean, and I actually was interested in medical sociology, and I did participant observation. I also collected the information, survey data on Korean immigrants in the churches. And I was thinking about all kinds of different things in this field that might influence serological testing rates. Mm-hmm. Well, to make a long story short, I did a historical study of the culture of Christianity in Korea and some background information on the field, the team that was going into the field doing the tests, the institution, that institution, its orientation to the community, and all of that. What it all boiled down to at the end, at least in my analysis, was that they were going to three different types of churches: Korean Presbyterian churches, Korean Methodist churches, and Korean Catholic churches. And Korean history and the history of Christianity in those context, was that the Korean Presbyterian churches were very hierarchically oriented and very conservative. And the Korean Methodist churches were a little bit less so. And then in Korean Catholic churches, nobody listened to the priest. So what was happening is when the team would go out and go into the field and would talk with the pastor or the minister, the Presbyterian pastor said, sure, come in and do serological testing. They had 90% screening rates. The Methodists had about 50%, and the Catholics had about 10%. So without knowing it in a way, I was doing this kind of field analysis. I collected all of the demographic information, the survey questionnaire, the attitudinal data. Nothing turned out to be statistically significant in terms of explaining the result until I looked at the larger field and what was going on there. So in a sense, I think that may be a kind of an old, in my sense, an old example, but it was an example of kind of a...
It's very relevant to what Dick was mentioning.
Thanks for your comment.
Ron, thank you. Okay. Yes, one more question, and we'll have to end it for a long day.
I'm Leticia Marquez Magana from San Francisco State University, and I'm very interested, I work at the Health Equity Institute, and we're very interested in understanding health disparities and how health inequities lead to these types of outcomes. And one of the things that I really appreciate about your presentation that seems to be missing in the other papers that we're presenting today is the importance of knowing the rules, like as you stated, or knowing the plot, which really is taking into account the culture, the behaviors, the practices, the beliefs, the values. And in fact, we know that disparities are due to differences in clinically appropriate, in the clinical appropriateness of particular treatments and prevention strategies, on and on, the ability to meet the needs of different populations, different population groups. And that sometimes there's also differences in the biases of the physicians and the stereotypes they have of their patients. And so all of that has to play out if we're going to make a difference in our country that's becoming increasingly more diverse. And so I think it just adds a whole nother layer that other people had brought up, but I think you were the one that really talked about the importance of having that being a central part of thinking about how to think across all these levels.
Good.
Thank you.
Very nice. Thank you very much. Okay, I'm going to turn this over to Steve. And Dick, thank you so much for excellent presentation.